All right, thank you all for joining us for our presentation today. You've logged into the Treatment Modalities Transplant at Home Best Practices webinar. Next slide, please. So today's agenda is featured on this slide. We're going to start with some meeting reminders. We're going to go into our transplant interventions and talk about the OKR a little bit. And then we do have a really great guest speaker for transplant. And then we're going to go into the home project, talk about that area. There is a wonderful guest speaker for home as well. And then we're going to close it out for the day. Next slide, please. All right, for some meeting reminders. So please mute your lines when you're not speaking to avoid background noise. We ask you to be present and be engaged in the call. And if you have questions, we want you to participate and utilize the chat feature to ask questions. If you do utilize chat, please comment using the all participants option so we can all see the activity. And then all of the meeting materials will be available in IPRO Learn at the conclusion of this call series. So by next month. Next slide, please. We have some objectives on the screen today. So for this presentation, at the completion of the call, all the attendees will be able to understand the current the current treatment modality objectives and key results. They'll be able to identify at least one best practice in the area of home and transplant to implement at their facility. They'll be able to understand the depth of a pro-transplant culture at a facility and how it can affect success, and identify barriers related to health inequity for patients and home modalities. Next slide. So my name is Caroline Sanner. I am the Quality Improvement Project Manager for the Transplant Project. And so I'm going to start off with the Waitlist and Transplant CMS Goals and Network Intervention section to tell you a little bit about our project and things we've been doing as a network to guide you all in your waitlist and transplant progress. Next slide. So as many of you may know, we at the IPRO ESRD network are contractors of CMS. In our contract, we're tasked with improving education and access to empower the patient choice of transplant. Within that objective, there's two key results that are being measured. It's the number of new waitlisted patients and the number of transplants. So just for some backstory, if we have any new people on the call, our contract's been in place since June of 2021, and it goes until April of 2026. Each year, there is a new goal that each network must meet in the area of increasing waitlist and transplant. This year, which runs from May of 2022 until April of 2023, the goal is to achieve a 5% increase in the number of patients you have waitlisted and a 6% increase in the number of transplants. So you might be asking yourself, well, how many waitlists and transplants does that mean my facility has to get, right? Because we're talking network wide. And if you can go to the next slide, I will explain. So we at the facility do performance benchmarking. We send out these performance scorecards on a monthly basis, so you at the facility can see where you started and where you need to be by the end of the year, and we help track it for you. So if you orient yourself to the performance report cards that you receive every month, you'll be able to know how many wait lists and how many transplants your facility has gotten credit for, and you can keep track of your progress that way. So we ask you, do you receive this monthly report? Typically, if you don't, we have you update your facility contact information in our contact database. You can also put a help desk ticket in if you need more assistance. You can get to both of these sites through our IPRO ESRD website or IPRO Learn. Next slide, please. So since our last best practice call, I wanted to highlight some resources that have been shared with the network, specifically geared toward facilities. If you've logged into IPRO Learn on a monthly basis and completed the interventions, these should be pretty familiar to you. We have a best practice guide and FAQ resource on staying active on the waitlist with monthly blood samples. The middle image is that performance scorecard. We did do an activity with that recently. And then on the right-hand side is a tips for positive transplant referral outcomes FAQ guide that was developed with network transplant centers to help streamline the referral process to reduce burden amongst all parties that participate in the referral process, so patient, dialysis, and transplant providers. Next slide. The network has also released patient-facing material in the last few months. The first was the Living Donor Transplant Your Best Option, which compares deceased donor and living donor kidneys, and also gives surprising facts that patients would want to know about if they're pursuing transplant. We do have the QAPI handout from the NCC that guides patients through participating in facility QAPI meetings. And then lastly, my dialysis plan, which is a resource that focuses on life planning. Next slide. So currently, for the month of September, we have two things live in IPRO Learn that I wanted to put on here that are very large developments, things that I've been working on for a long time, not just myself, but with many providers that might even be on the call today. So currently, we do have a Transplant at Home CEU course. It's a brand new course that we're offering. This marks our third CEU course that we offer. Through IPRO Learn, it's completely free for any of you who want to go in and get CEU credit. Along with this course, there is a quick reference guide for all of the material covered, and the course and the content were developed in a collaboration between network members and the IPRO ESRD network. So I encourage you to check it out. If you haven't yet, and if you need any free CEUs, they're there waiting for you to come grab. Next slide. Live as well as our high to low performance sharing intervention in IPRO Learn. So many of you have shared really great best practices with me over the phone, over email, even through IPRO Learn on our discussion board over the past few months. And I was able to extract 2 facilities per network and create an activity to highlight some very promising practices. So looking at your network and answering the questions is a required activity this month in IPRO Learn. But we decided to share every network's best practice activity with each other because some of them were too good not to share. And so I really encourage you, if you haven't gone into IPRO Learn, to look at what these great facilities are doing. Go in there, get the activity completed, but also take things that you've read and learned and bring it back to your own facility to improve your own care and your own metrics. Next slide. All right, so this is why you guys are all here. So the next portion is a real treat. I have Megan Mantler on the call today as our best practice speaker coming out of Network 1. Megan has been a gem to work with over the last several months. I first learned about her and her facilities' great practices like early springtime. So it's been a while since we initially spoke, and I was finally able to give her a platform to share what makes her facility so successful. So I'm happy to have her here today. I'm hoping each of you can listen, learn, and grab something great to take back to your sites. So Megan, you're free to start. Thank you.
Thanks so much, Caroline. I am very excited to share my enthusiasm for transplant and transplant positive culture in clinics with each and every one of you today. We can go with the first slide. Great. So we've sort of outlined a couple of things that I'll be discussing today. We'll start with looking at my facility and its demographics and how that plays a part in how we formed our transplant positive culture. Then we'll go ahead and look at some of the ingredients that make up our recipe for success, different educational approaches, how we go right head on with overcoming those health equity barriers, and just kind of how we've worked toward this pro-transplant culture. Then we will end with a case study that kind of shows a typical way our clinic works with all the members of an IDT to make this happen for people. Next slide. So here's a little bit about DaVita PDI Worcester. We're right smack in the middle of Massachusetts in Network 1. and we're a very large city clinic. We are right in the middle of Worcester, and we have 5 shifts, over 100 patients. Our home program is over 30 patients big as well. So we have, new patients starting every single week. 2 very large hospitals in the middle of the state are our main referral sources for dialysis patients. So we have a lot going on. And we also have at least 7 doctors that round at our facility. So there's a lot going on. And we have just really done a great job figuring out a way to work with our transplant centers, our doctors, all of the IDT, and most importantly, our patients and their families. We have been able to continually get folks waitlisted and stay waitlisted, as you can see. And we've all been in just awe that we've been able to transplant 18 patients recently. And it's almost like, bam, another one, bam, another one. We've all been just so excited. There's so much squealing in the clinic. It's amazing. Next slide. All right. So let's get into the ingredients that make our recipe just taste so good. We are a transplant forward and transplant positive clinic. Transplant is a word you're going to hear from your social worker and your doctor, probably your first or second treatment with us. It's going to be a word that you may have even heard from your doctor in the hospital before you even got to our outpatient clinic. So DaVita has developed an amazing resource called Smart Start Welcome and Transplant Smart. And they are a series of videos that are in English and Spanish primarily, but then we have either like index cards or actual like binders with all of the same information in 12 other languages. And we sort of have created like a get to know dialysis curriculum, and it's nationwide for all DaVita clinics. We use these tablets and we sit down with the patients. It's typical that maybe the AA may do the first or second video depending on the clinic culture. However, in my clinic, the social worker is the main starting point. So we are the ones that work with this education. The education is done with sort of a minimal sensory distraction. It is a very clean cartoon, but is not a cartoon that would appeal to a younger person. It's just a very clean looking cartoon at a 4th grade reading level or 4th grade vocabulary level. And it's plain animation that appeals to different patients. The colors of the screen just don't sort of make it as if it's one culture or another culture. It's very plain. All patients have an opportunity to watch these videos or use the binders that sort of are the flip cards of each scene in the video. And we have the information available through our translator as well. And then we show these videos to the patients every week, essentially, that they're on starting their dialysis journey. We even have videos that are real live folks, real live people that have gone through AKI and then want to talk about getting listed for transplant. And then one special video that I want to talk about is that we have a video of one of our former patients here in Worcester who now works for DaVita as a nurse, and he is a transplant recipient twice actually. And he made a video with DaVita National, and I love showing my new patients. This is somebody that sat right in that chair right over there. You see, that's the chair that he sat in, and now he has a transplant, and he did this with his life. And watch his story. You can imagine him sitting right there, this guy on the screen that's talking to you. And boy, does it mean a lot to a lot of people to sort of see that this is real, live. The people that are working with them in their chair, giving them dialysis, they helped this person too. Wow, if they can help him, they can help me too. It's amazing. So that is something that's really special to us. So I would sort of suggest to all of you, if there's a success story and you can get that person to sort of bring in maybe a newspaper article they did when they got their transplant, or a video they made for their worship community, utilize it in your clinic. It means a lot. And then we also just have all this printed material readily available for patients upon request. Tip sheets for making a live donor profile, tip sheets on how to order like the back of your car, the stickers that go in the back of your car, you know, Nancy needs a kidney, that sort of thing. Just tip sheets that are available that we can just print out at a moment's notice and say, yep, this is what you wanted, here it is. Next slide. Great. How's everybody doing? Thumbs up? Good. Okay. Now, Caroline reached out because I know she is really interested in looking at overcoming health equity barriers. And it was a great conversation. So I thought I would just share some of the ways in which we come to that conversation here in Worcester, which is in New England. You know, we have a high commitment to helping immigrants here in Worcester, Massachusetts, and that is shown in our patient population. So one of the ways that we found that this works really well is encouraging peer-to-peer support, because organic networks is how people learn naturally. So instead of it being a teacher-student relationship with power dynamics, why not encourage patients to speak to one another? Why not encourage patients that have similar journeys or similar backgrounds or similar stories and hurdles to go jump over, work with one another? So be strategic with your charge nurse about where to sit people in the clinic. Be strategic about hanging out in the lobby and sort of finding a HIPAA compliant way of being like, so how much have you ever talked to this patient before, you know, and just kind of connect folks. They already know each other. Find a way to sort of get them talking with each other to support each other. We have done that on a number of occasions, and it turned out having patients drive other patients to appointments they couldn't otherwise get to, or a patient giving another patient a resource that was specific to Mexican Americans that were on dialysis needing encouragement. And it took the power dynamics away and put patients at the center of their own journey. And it works really, really well. And so we kind of call these like peer mentors, peer advice mentors, and we have a couple in our clinic that we know we can call upon for any patient, but we really do try to match folks up by the barriers they're going through or their stories. Next slide. All right, great. So I have sort of two examples of how I've worked with transplant centers at the hospitals in overcoming health barriers and health equity issues in New England. If some of you that are in Network 1 don't know yet, MGH, Mass General, has improved some of their care in the last couple of months, and we've been able to utilize this here in Worcester. Mass General now is operating an equity clinic, which they do a kind of funny thing with KT over V. It's like EQTOV, equity. It's kind of adorable. That practices telehealth with the patients, so that maybe they're living in Springfield, Worcester, Rutland, but they can do telehealth to Boston so that they don't have to drive there. They're also trying to get all of the workup done in 1 or 2 appointments rather than dragging it out over 3 months, so that patients who work, you know, double shifts, patients that have childcare duties, don't have to keep making trips out to Boston. And then the biggest news for them is that they are now accepting undocumented and mass health limited patients at MGH now. If you don't know that yet, now you know, and it's kind of amazing. So your New Yorkers, your New Hampshire folks, you can go to Boston now for undocumented folks. They have a special priority in engaging with collaboration. They have multiple languages that are spoken at the Equity Clinic, and that way a person whose native language is the same as your patient's native language can call and make all those appointments for them, and over the phone education, so that the patient is actually understanding what they're signing up for, which is a huge plus. And I've had a person that's on the programmatic side of MGH transplant call me and say, I speak Creole. I'll call that patient and explain everything to them. Like that's pretty amazing. And then both MGH and some of the other transplant centers in New England are utilizing their financial counselors to work with the patients a little closer to make sure that they're keeping up with their insurance and having the right kind of insurance to get everything they need for their transplant process and post-transplant process. And what I've done is kind of actually know the name of the financial counselor, make sure I'm calling them once every quarter to check in. Any patients at my facility are having any issues that I need to know about? Can I help follow up on those issues with you? A lot of us don't know the name of the financial counselor that works with the transplant department at your transplant facility, whatever state you're in. Get to know them. They can be your friend for sure. They can get those colonoscopies approved by the insurance quicker than we can. Any questions there? Call to schedule an evaluation if they're out of state. So I see that question right there, and I can get the contact. I'll send it to Caroline, and she can probably send it out with the wrap up, right, Caroline? I would assume. Yeah. Okay. I'll get that to everybody. And they are taking patients out of state that are contracted with MGH, which is a pretty wide range of states, in fact. Yep. Next slide. The local hospital here to Worcester is UMass Hospital, and UMass has a great transplant program as well. And we do something really special with UMass because about, I would say probably close to 80% of our patients are listed at UMass, not one of the Boston hospitals. So we have really close contact with them. What we do is my other social worker and I that work in Worcester have a monthly meeting with the two RN transplant coordinators at UMass, and we use the roster that you should be getting every quarter from all your different programs, and we go through each patient by name. We'll say, John Smith needs colonoscopy, needs stress test. We write it down. We find out and make sure that they're active or inactive, maybe the next appointment they have available, and we write it down so that that's the very next conversation we're having with that patient. What that does for our transplant forward and transplant positive culture at our clinic is our patients are hearing about transplant every single month from us. It is not a once a year assessment question. We are constantly talking about transplant. I have in the back of my head when I'm putting my kids to bed at night, like XYZ patient's next stress test is coming up. Like it's always there. I'm always talking about transplant. And it's an ongoing process, and that keeps patients really excited. So continuing to meet with your RN coordinators is super important. We talk about the barriers. They'll let us know barriers we didn't even know about, so that then we can go and talk to the patient about that barrier and help come up with a solution. So here's a great example of something we've done in the last couple of months. A patient needed a stress test. the transplant center called us and said, did you know that this patient canceled the stress test 2 times? Can we just give you the number to nuclear medicine so that we can reschedule? So I take the number to nuclear medicine. I meet with the patient. I kind of use motivational interviewing for all your social workers out there to find out what's going on with this stress test that's not getting done. Provide some health literacy about what a stress test is, why does transplant need it, what is nuclear medicine, why are they performing this test, and we call literally right there while they're on dialysis on the clinic speakerphone and schedule that appointment. This is something I actually did. It encouraged personalized care because some folks would be very scared. What is nuclear medicine? Is somebody sending me to the moon? What's happening, right? So explaining it in the moment and taking the fear away by saying, I'm going to be right next to you on speakerphone when we call and make the appointment. And then we bring it right down to the level that the patient needed that to be brought down to, instead of something that seemed really out of their control. So then we let the nephrologist know that we did it. We also let the transplant coordinators know that we made the appointments so that they both can follow up and give positive encouragement to the patient. We let them know that the patient went to the appointment, or transplant might email me and say, hey, it looks like they went, great job, woohoo, they can move on to the next step. And then we write a note and everybody's doing great for the next step of the process. I think I'll answer that question now. How do you get monthly meetings set up with transplant coordinators? So I'm also the regional point social worker for my part of New England for DaVita, and I've helped and encouraged all my social workers to just, it's an expectation that you get in contact with that transplant coordinator of that hospital and you say, I'd like to meet with you once every 3 months. Or I'd like to meet with you every other month on a rolling basis to go through our roster and just quickly mark off what needs to be done for the patients. And you just set it up as very reasonable, you know, every other month, every 3 months. For us, it's every month just because we have so many patients on the wait list at that particular hospital. Okay. All right, next slide. All right, pro-transplant culture. Caroline asked me a great question when we were preparing for this. She's like, you know, this seems like difficult, or what would you have as advice for other clinics that wanted to turn it around and have a pro-transplant culture? And that was a hard question because I felt like it was sort of already in place when I got here and we've just expanded it. And I thought about it for a while, and I truly believe what it is it has to do with our language and our attitude towards transplant. So the language, instead of having a patient sort of like the check mark on the plan of care or the assessment of, okay, transplant active, great, okay, check mark. It's like, how does transplant, how is it a part of your life? It's one aspect of all of these other things going on in your life. It's not like something you're just checking off. So what do you want your life to look like? And how does transplant fit into that? Not, oh, how do we get that transplant thing done? It's not something that's on a to-do list. It's always a part of your life. So what do you want your life to look like is kind of how you approach it with a patient, rather than making it like your phosphorus is 7. And when was the last time you saw transplant? And then another way of looking and approaching this that I implemented when I came on board here was, I'm always using the phrase, what's the plan? With our doctors, with our monthly rounding, with our patients, with transplant. It's not, do you want a transplant? Would you like a transplant referral? Everyone here will learn that I'll sit down for that initial assessment and say, so what's our transplant plan? And then they'll say, I've never heard of it, or tell me more, so that then they know that there's going to be some action somewhere with transplant. It's not going to be something that I'm going to give them a phone number to refer to. It's an action plan that's continually evolving, just like that plan of care is that we do every year for our patients. It's constantly being worked on. And it's a part of your life plan. It's just as important as an advanced care plan. It's just as important as choosing your modality, because in fact, transplant is a modality, right? So it's just, what's the plan? What are we doing to make this happen? And that's why some people could be going for a deceased donor for 5 years and then all of a sudden be presented with the opportunity of a live donor. So the plan changes. So what's our plan now, right? Those are sort of the two examples I had, and it was really hard to think of what it was. Next slide. All right. So more about the transplant culture that we have. We encourage improvement outside of the walls of your dialysis clinic. Because we're high performing in this particular clinic, we have a lot of things that we do that go into this amazing work that we do. We have no clue how we do it, but we do it. And I've spent a lot of time with my other social workers doing one-to-one coaching calls, helping them rethink how they're talking to their patients about transplant, rethinking about how often they're looking at their transplant waitlist rosters and sort of turning the red into green, however you want to look at that, making it a part of your work week just as much as the patients need to make it a part of their life plan. Not just something you look at the end of the month to update your metrics. And then it was really, we all felt a lot of burnout during COVID, and we feel a lot of the burnout with low staffing, but making sure your team is educated on transplant too, making sure your PCTs and your tech and your nurses get education or hear you giving education, so that they're not spreading transplant myths and they're just as excited about transplant as you are. They're the ones that are spending so much time with the patient. So as long as they are pro transplant, your clinic will be pro transplant. And then just providing that support and guidance to help change the mindset and approach for both your techs, your nurses, your RDs, and your patients, and your doctors. My goodness, the doctors sometimes need to have new life breathed into them about transplant too. Yep. Next slide. All right, we'll end with this. Case study that I will do my best to be HIPAA compliant here. We have a great story of a patient who was transplanted, and this is a story of engaged staff and working with an IDT. So I just thought I'd kind of tell this story as an ending point, and hopefully you can take pieces of this and apply it to your patients. We had a patient that was transplanted at a very young age with lupus, and she had this transplanted kidney for quite a long time. She at a sort of very young adulthood, that kidney failed and she was back on dialysis. Not going to college, sort of here and there, maybe doing a class, never holding a job, got herself SSDI, came on first shift, was well liked. Everyone sort of loved talking to her, and she gave out a lot of great positive energy to other people, but was just really content on dialysis. We were her social circle. We were her caregivers. We were her healthcare team, right? Like, she came to us with personal problems, with health problems, and was always like, oh, I'll think about transplant when I'm older. Oh, I'll think about transplant when I'm older. I want the kidney to last a long time, like just really a young person's response to this who had been sick her whole life. And then I sort of started to dig into it instead of just saying, so you still don't want to go for transplant? It was, what's the transplant plan? I started turning the language around, and it made her start thinking a little more. And she had some underlying reasons for not wanting to pursue transplant. She hadn't had a surgery that big since she was 7 years old. She was scared of the surgery. She didn't know what it would be like. She was really afraid to get a pap smear done, which is a part of the typical cancer screening for a transplant workup, and had never had one done before. She was really scared of losing her SSDI, losing housing, and what her life might look like post-transplant. And then she was admittedly to us scared to lose us as a support system every single day seeing us, right? So we had to enroll her in Davita's version of CBT therapy that we have here, where I worked with her on all these things. We got her to do some exposure therapy where she hooked up with Child Life at the hospital, even though she was a little older than Child Life might typically work with her, and brought her into an operating room and showed her the procedure and showed her the instruments. And for the pap smear, I asked her nephrologist if he knew anyone that might do really well with like a youngster. And he found someone, and the patient really liked that person. And through trial and error, it got done, and she, was able to finish up her screenings. And we did a lot of research on how and when she would keep all of her insurance and her SSDI and whatnot. And we kind of had everything sort of laid out to where it all made sense to her. So she, drug her heels a little bit, got the workup done. And I think the official count was she was on dialysis 15 days post being activated on transplant, and got the transplant 15 days later. It was something like 9 treatments after she was activated that she was called for a transplant because she was so young. And that's the kind of work we do. We engage everyone on the IDT, and we go above and beyond, and we keep working on a plan. And she had been on dialysis probably 6 years before I got to Davita, with absolutely no work on transplant at all. And that's my story, everyone. I'd love to either answer questions now, if that's appropriate, or later, Caroline, whatever works.
If Stephanie, you can go to the next slide. Perfect. So thank you so much for sharing that. I love hearing it a second time, even hearing it a few times, making the slide deck and hearing it again. It's still wonderful. It gives you that feeling that you get when you're doing good things and helping patients. And I'm so glad that the crew that is joining us today was able to hear it live from the source. But before we close out the transplant section, does anyone have questions that they want to ask, whether it's through chat? If you have questions, put it through the chat, and we will repeat the question and answer it to the best of our ability. I think actually a majority of the questions you answered as we went through. So due to chat kind of, here we go. We'll do this one that just came up. How do you know the patient did not feel pressure to get transplanted and that's why she went ahead with it?
Because I remember that she was first shift, so I would check my email and stuff before I would go out on the floor. And I remember one day sitting in my office checking my email, and one of the PCTs came in my office and said, I'll just say a name, Sandra. Sandra wants to talk to you about transplant. And I was like, oh, really? I'll be right out there. And I ran out there and I said, what's going on? And she's like, I just want to know. This is all I want to know. I want to know what the workup is like, and is there a way I could like see a video of the surgery? And like that's how she started the conversation. It was on her terms. So then it was, yes, I'll get you in touch with Child Life and we'll start there. And then I said, could I tell and I call them the girls at Transplant, the two RN coordinators. I said, can I tell them you're getting interested again? And she's like, as long as they don't call me, yes. So when I told them, they, were yay. And it took, I would say, another 2 months before we sent in an official referral packet. So it was all on her terms.
I think that does kind of show that it was your language and your approach that made the patient bring transplant to you instead of just from a pressure perspective. I think that answers that question pretty well.
Mm-hmm.
And then I see a question. How do you handle patients living in nursing homes if you do?
That's really tough. The feedback I've gotten from transplant centers is, Megan, if you can identify a support person for that patient, so maybe a family member that lives in the city that they live in, then we will absolutely see them and work them up. As long as they have another support system that is not the nursing home, we'll see them. So we've had some successes and we've had some misses with that. And then the other little thing I'll say about that is talking to someone at the nursing home that will be your advocate to make sure that they're attending all these appointments, because you shouldn't have to be the one chasing that. Just finding somebody else at the nursing home that is excited about it, that will actually make sure that the patient gets brought to all those appointments.
Carolyn, I don't know if you saw the question about how undocumented people get their medications paid for. Just want to make sure
Yes.
put up the chain.
That was going to be the last one that I'll ask before we go to home, just to make sure that they have enough time.
Yeah.
So we'll do one more question. It was, did the hospital need encouragement to give transplants to the undocumented patients? How do they pay for the medications?
Boston Medical Center has a grant, and they pay for the medications. Is Boston, at each hospital it's different. So Boston Medical Center, it's one way. MGH, we haven't had someone get transplanted since, but I believe it's all a part of this health equity plan that they're putting forth, that they're going to be sponsoring that with a grant. And those are the two hospitals I know that do undocumented immigrants.
Wonderful. So for Jennifer Griffin, who asked that, and for anyone listening, I would say reach out to the hospital that you're referring these patients to, or reach out to your local centers to see what they have in place for these types of assistance. Some I know have no special assistance, but some do. And then for anyone else who asked questions that we haven't gotten to yet, I will make a note of them and we will get you the answers. But I do want to pass it over to Michelle Prager, who is our home therapy lead. So Stephanie, if you can go to the next slide. Megan, thank you so much for coming today and sharing all the great stuff that you do at your job. It's incredible to hear your facility's success. So thank you very much.
Thank you.
Good afternoon, everybody. I'm Michelle Prager, the Quality Improvement Home Lead for IPRO, and today we're going to talk about talking to patients about choosing a home modality. Next slide. Thank you. Oh, thank you. So as Caroline talked about, we are contractors for CMS, and these are what our goals are to get patients on a home modality. So this table shows our goals. The 5-year goal for incident patients, meaning patients starting directly on home, is 60%. In our current year, performance goal is 10%. And then for prevalent patients, which is transferring to home modality, the 5-year goal is 30%. And the current goal is 2%. And then utilizing telemedicine for home patients that are in a rural area is 20% for the 5-year goal and 2% increase for this year. So some ways to drive these goals, using the NCC change package, monitor the use of telehealth, and engage patients in work by sharing best practices. Next slide, please. Recently in IPRO Learn, we put out a article synopsis titled Racial and Ethnic Disparities in Home Dialysis Use in the United States, with Barriers and Solutions. So the article reviewed the following 4 barriers: physical conditions, meaning like space issues, unstable housing, access to dialysis with home, and high socially disadvantaged dialysis units. Social conditions such as financial barriers, transportation, lack of caregiver support, and poor health literacy. And then healthcare systems, lack of pre-dialysis care, lack of modality education, lack of high quality language interpretation, discrimination in healthcare, suboptimal dialysis starts, and lack of pre-dialysis insurance and poor nephrologist familiarity with home therapies. And then healthcare policy, they looked at penalizing facilities caring for socially disadvantaged patients, proposed exclusion of beneficiaries with social barriers from alternative payment methods. Next slide, please. So between all the networks, we found that 47% was the social conditions, which is what we see a lot: the financial barriers, lack of transportation, lack of caregiver support, and poor health literacy. And then followed by that were the physical conditions, which is space issues and housing issues, access to home, and then last is healthcare policy. Next slide, please. So the article proposed some solutions to each barrier. So looking at some of the physical conditions, community housing, funding assisted PD and home visits and telehealth. And then for social conditions, they talked about patient financial incentives, telehealth visits, funded assisted PD peer mentoring, and cultural language concordant education. And then for healthcare systems, improve access to dialysis care, nephrology care, culture, language, concordant care, and education, urgent start PD programs, provider financial incentives, improve trainee education in home dialysis. And then with healthcare policy, they talked about disparities, sensitive quality measures, social risk factor adjustments, social needs screening, payment adjustment for social determinants, leverage incentives to address social needs, and study policy effects on racial disparities. Next slide, please. There should be one before that. So what can you do to make a difference? Working with patients and families individually to see what barriers they have and what are their priorities. Think outside the box for some creative solutions to help patients reach their goals. Investigate social support systems in the community that may be able to help the patient, and believe that everyone deserves an opportunity to consider a home modality. And then this leads me to my guest speaker, Morgan Cornett. She's a facility administrator for DaVita National Trail Dialysis, and she has done some of these things in her clinic to overcome these barriers. So I'll let her go ahead and talk about some things she's done. Morgan?
Can you hear me? Can you guys hear me?
We could hear you, Morgan. It was just very muted. Are you there?
I'm here. I just don't know how to make that
Oh,
better.
there you go. Now it's better.
It's better.
Okay. So this is my first call, so bear with me on these things. Can you go ahead and go to the next slide? Okay, so some things that I'm going to talk about that's worked for us is kind of what we call the secret sauce to how we got to where we are today. Some of our techniques with educating our patients as well as our team. We are very home culture here, like that is our first priority for patients. And that is definitely a culture at our clinic. And then overcoming some of the barriers that we've encountered. Next slide. So big thing for us is our medical director is our primary nephrologist here. He is very involved with these patients, and the education with them begins in his office before they even see or hear about the dialysis center. We present to them in his office their options, and we usually lead with PD as the first choice and then make the other options like backup plans if PD should fail. That's how we tend to present it. We also have a home RN that is stationed outside of my clinic. She works here 5 days a week. She used to be my in-center nurse primarily, so all of our in-center patients have a very good relationship with her. So that helped a lot with the trust and transitioning some of our current in-center patients to PD. We also named recently, this is a new thing that our region kind of rolled out, is we created a home champion, and I specifically made that a patient care tech because in my past experience, I was a tech. I know that we prefer to have our easy patients stay in center. So a lot of those patients would actually thrive on home. So we made a patient care tech the home champion so that they get a little bit of a bonus for helping transition those patients, and it's not just the patients that they don't want anymore. Next slide. Okay, so some of our barriers, the biggest barrier for us is definitely transportation. Our local transportation companies do not cross county lines. So when we have patients that we get placed at our center that don't necessarily live in our county, we definitely present to them home first. We do it with everybody, but we make it a priority to make them the first people that we speak with, because I know transportation is going to become an issue for them. So that is definitely one of the things we have dealt with here. We do have a really good transportation company that will work with us to get them here for training if we are going the PD route, so that they can get the training they need so that they can go home. So they only need that transportation across county lines for short term instead of indefinitely while they're in center. We also have several patients actually that deal with homelessness. It's just kind of our demographic in the area. And one of our patients specifically is and has been living in a hotel. So she does very well. We make sure we make arrangements for her to get to appointments. We make sure that we make arrangements for her supplies to be delivered to her hotel room. And it seems to be working. It's just what was better for her. She was able to do her own care with her husband and not have to worry about getting to and from the clinic. So we definitely have come across some very interesting barriers that I think if you really put your mind to, you can overcome. We definitely targeted, when I first took over this clinic a year ago, our mistreatment rates were off the charts. And so we targeted those patients and kind of deep dove why they were missing treatments. Was it a transportation issue? Was it a just straight non-compliance? They don't want to be here. Was it they don't like the needles? You know, kind of what the issues were that was preventing them from coming to treatments. And what we found was a lot of those patients, felt kind of crummy after they left, or they did have that fear of needles. So we, would encourage them to consider moving over to PD, which is what we predominantly do out of my clinic. And Stephanie, who is my home nurse, and she was my in-center nurse at the time, we kind of worked together to target those patients and make sure that they got the best care that we could give them and what worked better for them. And actually our mistreatment rate has gone down significantly as most of those patients have transitioned. Next slide. One of the big things that we do when I say we promote home culture is we start educating our patients on day one. And actually, if I'm being honest, it happens before they even come to the center. It happens in the doctor's office with our physicians. They present to them their options and lead with peritoneal first. And then once they come in center, the first face that they see is our administrative assistant, and she starts talking to them right away about their options and what PD would be beneficial to them, and kind of help explain the benefits to it. And then again, we do have a really good rapport, and we have a whole team support of getting these patients transitioned over. Our medical director is extremely, extremely involved. I can't stress that enough. He knows these patients as well as we do, some of them probably better. He has their personal phone numbers. You know, we really work with what's best for our patient, and he supports that all the way around. All of our PCTs are educated on PD so that they can help educate patients. They can help answer questions, because sometimes those relationships are better with the techs and the patients than they are with some of the other people that are approaching them, you know, our social worker or even our home nurse. If she doesn't already have that relationship built, they necessarily don't trust her. So our PCTs are all educated and trained on PD so that they can answer questions moving forward with the patient. Next slide. Kind of our thing. Anything I can answer?
I have a question. How did you get supplies to the hotel? Were they willing to deliver there?
They sure were. Yep, every 2 weeks they deliver there.
Oh, so you did it in a less, and your company isn't having any problem with supplies coming more frequently? I know some people are talking about charges increasing if you do more frequent deliveries. Do you guys have any of those problems? Because we've been trying to look at that as a barrier to overcome.
So yes, we have come across that. Ultimately, we've just kind of decided that that's what's best for the patient. And we, like I said, we have a lot of support from our team as a region.
It's great.
Any other questions for Morgan?
I think, you know, and one that's coming through, not really in a question, but I don't know how she's been able to deal with the staffing problems, because we hear this a lot, right, Michelle, from home programs, is they're missing people, can't refer. I don't know if there's any creative practices like referring around your local program or anything like that your region does, and staffing issues.
So we do have some staffing shortages. That's definitely a thing here. Like I said, my home nurse is predominantly in my clinic, so she sees all of my patients first. But she does float out and help other clinics in the region as well, and the other home nurses in the area do the same. So it's kind of a team effort, not a clinic like siloed.
So if somebody lost a nurse, they could go to a different center and get trained versus waiting.
So what we typically do if we lose a home nurse is one of our nurses travels to the patient versus the patient traveling to them.
Wow, that's an excellent solution.
Morgan, there's a question in here. Is your whole physician group pro home?
They are.
And are they fairly new, or they've been doing this like their whole practice being pro home?
So the one that's predominantly over my clinic specifically has been doing dialysis. I've known him for over 10 years. And the other two, one's ready for retirement. So he's been doing it, you know, since the early 80s probably. And the third physician, I would say he's probably been in the practice probably 7-8 years. But like I said, it's a practice culture. So he just adopted the culture with the rest of the team.
So kind of like a peer pressure, right?
Pretty much.
I don't know if you saw this one, Michelle. You seen the one about the mistreatments?
Yes. Have your mistreatment hemo patients done well coming to PD training and clinic appointments?
So yes and no. We've had some that have been very successful. We set it up very clear for them. You know, you have to come to these appointments. You only have to come to see the clinic, you know, twice a month, one to get your labs, one to see the physician. And then the training sometimes takes a little bit longer for those patients. Sometimes it gets pushed out about 3 weeks as opposed to the, you know, standard 8 to 10 days. But we do our best to work with them because we know in the long run it will benefit them as well as the clinic.
Have you had any, we've had a couple difficult situations where patients are non-compliant or missing sending in documentation for their home treatments or whatever, and the clinic has a really hard time kind of getting them back in line. Do you have any advice about how to prevent that from happening when you kind of are dealing with some of these patients who may be less willing or able?
Yeah, fortunately, we really haven't had that issue specifically, but I do think that if we got to that point, our medical director would step in, as he is their primary nephrologist as well, and he will tell them, very honestly, this is the expectation, and if you can't do it, we will move you back to chemo. I mean, it's a very tough but honest conversation.
And probably pretty quickly on when you notice a problem, right? I mean, not.
Oh yeah, it's very apparent, I would say. If you're going to have issues, you're going to notice them pretty quick. Usually we see those patients coming in training, so we kind of head that off then.
Do you offer telehealth for people at home or no?
We do not.
I don't know whether anyone out there has found that that's helped a little bit with some, patients getting back and forth, because it's a nice way to supplement your clinic visits.
There's another question in here, and I'm not sure. I think, Morgan, you're in a somewhat rural area, but somebody was asking, they're in a rural area, their program's 2 hours away from other clinics. For patients getting to a home unit for training multiple times a week is a barrier, 4-hour round trip with gas prices and time away from work or having a driver. Any suggestions? I don't know if you've run into that, Morgan.
Not specifically the distance, but
Your volume is very low again, Morgan.
sorry. Sorry, my phone is ringing. I haven't specifically run into the distance being an issue, as far as we do have a patient who is an isolation patient that went from in-center to home, and training him became kind of tricky. So what we did, we trained him in his home. So our nurse traveled to him. That way she could get that might be something you could look at for those patients. You pay your nurse the travel as opposed to asking the patients to travel to you.
I was going to suggest that as well. I know that there are some companies that will allow the nurses to train in the patient's homes.
Yeah.
That's a great suggestion. And then maybe this patient could be supported with telemedicine visits, so they'd only have to come in like once a quarter, as long as everything was going okay.
Or like I said, your nurse could travel to them and get their lab work, and then they could do their telehealth visit with the physician. Yeah.
Yeah. Oh, did you see the next one? Usually hotel has a limited stay. What happens then with unstable housing?
So the patient that currently lives in a hotel has had some issues with her hotel, and she has had to change hotels. And it's just like when they move, we just update their addresses and do our best to support them through that move. And she's very good about letting us know if that's going to happen. We've even suggested, having her supplies brought to the clinic if that's what we need to do, and then getting them to her when she has her visits. We haven't actually had to do that yet. We've been able to just update her address and get the supplies delivered to her new residence. But I think it's a good thing to just have working relationships with those patients, because, right, they're always going to have, they got in these situations for a reason. So they're always going to have those barriers. They're always going to have an issue why they can't get their supplies, or they can't get to treatment, or whatever the case may be. So I think if you just go into those conversations knowing you might have to do a little extra for that patient, the reward will be beneficial for them in the end.
There's a question in here. How can we increase home therapy patients if physicians are not involved? I would say have a conversation with your physician. A lot of times I've read different studies done saying they've asked physicians, if you had to start on dialysis, what would you do? And a lot of them choose a home therapy. So maybe looking at why would you choose a home therapy for yourself but wouldn't advocate it for patients. So maybe it would be worth having a conversation with the physician about why they're not educating patients on a home therapy.
And sometimes, Michelle, another option is if you have like in your group or another clinic where there is a physician who's very much a champion, those physician to physician conversations can be really good. I don't know if this person works in a group chain or setting where they would have access to another physician, but I found that those conversations can be really beneficial, like a physician who really believes in home and supports it, actually kind of working through like what's going on in your group and what's the ideas and why, what can we do to get you to look into home more. So that kind of peer-to-peer thing works well.
Yeah, and another thing I would add to that is a lot of times especially with our physicians, like I said, they give us a lot of support, but some of our other clinics that are nearby, the physicians aren't as supportive. We really encourage the team in those clinics to educate the patients, because when the patient goes seeking the information from their physician, it kind of puts the physician on the spot. Like, why are they allowed to do it, but we're not? So they have a harder time saying no.
Oh, that's true. Yeah, yeah. Again,
Yes.
that kind of peer pressure thing, right? That's a great thing, Morgan. And sometimes, you know what? Sometimes hearing from a home patient who's doing so well might even change a physician's mind. I mean, I know some patients, they could advocate so much, and that might be another option, even if patients aren't bringing a patient advocate in. Like, you could feel so better on home, and that there's very passionate patients about how well they feel on home, and they can be big advocates not only to maybe convince physicians or convince other patients. I like the comment about FMLA covers time away from work for training due to medical nature. So interesting for patients to consider or talk about that and the traveling nursing.
Morgan, there's another question in here. What is your average training duration for CAPD and CCPD? How many weeks of training for the patient? I know you don't have HHD at your clinic.
So from start to finish, probably 4 to 6 weeks total.
Is that catheter placement included, Morgan, or is that actual training time?
That's with catheter placement.
Okay, so 6 weeks total with catheter placement. There's a question, I think, that above that, Michelle, that said, do you have many patients that transfer from in-center to home several times?
No. We've kind of created that culture where when we go to home from in-center, we exhaust all options before we bring them back. And then once they come back, we really, like I said, we exhaust everything before we bring them back so that they don't ever really try to go back to PD. It's usually if they have to come back in-center, it's for reasons other than them. It's their body's not handling it, or they're having drainage problems, or things that are just out of everyone's control.
I don't know what this question means. Maybe you're looking at it, Michelle. As far as reporting, how do you handle it? I'm not sure what reporting of what.
Sure either, but I did see a comment in here. It said, fantastic teamwork with your clinic, Morgan, advocacy on all levels. And I couldn't agree more. You have a physician champ, a home champ, and a total team approach.
I think that if you go into it thinking about what would you want as the patient, it makes things a lot easier. As opposed to, what's best for my numbers or what's best for the clinic. It's what would you want if you were in that position? If you were the patient, how would you want to receive treatment? And it kind of changes your perspective on things.
And I think that's it from a question perspective. What I can see, Michelle, I don't know if you see any others.
Yeah, I don't see anything else. Thank you so much, Morgan.
No problem.
Yeah, excellent presentation.
Wonderful.
Okay, Carolyn. Oh, we got some hands clapping up there, and we do have a request. Carolyn, are you moving to the next slide?
Yeah, I don't remember if there is another one, but wonderful. So thank you all for attending. Hopefully I know I learned something, but hopefully you all have learned something that you can take away from this best practice call. This will be posted on IPRO Learn on the 1st of October. So if you need to view it again to catch anything you might have missed, or you want your other facility staff members to view it, it's going to be on IPRO Learn on October 1st. And when you log out of this call, please complete the post-webinar survey. It allows us to better tailor calls and different webinars to your liking in the future. Thank you all for attending.
And thanks to our best practice speakers. You both did an amazing and wonderful job, and we couldn't do it without you. You're doing it out there in the field with such great examples. Thank you for sharing with us today. I think when this ends, we are going to get the pop-up survey. So we are closing out of the meeting. Thank you.